Case 3 is going to be the case that all of us are afraid of. This is the rapidly progressing metastatic stage 4 lung cancer patient following immunochemotherapy. So this is a 66-year-old lady who's a current smoker. She was diagnosed with high-grade lung adenocarcinoma 7 months ago. A CT scan of the chest shows 3 lobular lesions in the left lower lobe of the lung, about 4.5, 2.1, and 3.3 centimeters. And at the time of her presentation, she had widely disseminated brain mets. Now, she did get whole brain radiation, and while that's done, she did have molecular profiling of her tumor. Unfortunately, it didn't show any actionable driver mutations, but you did get a little additional note saying the tumor cellularity was poor and they didn't do the FISH analysis. So this is, again, one of those things that make all medical oncologists cringe. The PD-L1 was also run, or supposedly run. Unfortunately, it comes back indeterminate. So you don't even have that piece of information. So she ends up getting carbapenem pembrolizumab, and her CT scan at 12 weeks shows massive progression in all 3 lung lesions that you were following. Now, she had had whole brain, so her brain disease was stable, but she now has new liver mets and new bone mets. She's got worsening fatigue, and her PS, which used to be a 0, is now a 1. So I want you guys to keep that in mind while we review some of the data. And this is a subset analysis from the REVEL trial. So the REVEL trial, just a brief recap, was a phase 3 study of docetaxel with and without ramucirumab for second-line non-small cell lung cancer. And the study originally came out before the era of immunotherapies hit. So I'll just recap very quickly the study design. So this was for all stage 4 non-squamous or non-small cell lung cancer patients that included both non-squamous and squamous cell carcinoma. Everyone just had to have at least 1 platinum-based chemotherapy with or without maintenance therapy. They could have had prior bevacizumab, and the performance status had to be 0-1. They were stratified by PS, also gender, prior maintenance therapy, and also, since this was international, they also stratified by location geographically in the world. The primary endpoint was overall survival. And when they did the treatment, the ramucirumab was given at 10 milligrams per kilogram, and the docetaxel in both arms was given at 75 milligram per meter squared. And so patients continued on treatment until progression or unacceptable toxicity. And again, there was a significant overall survival benefit. Ramucirumab added to docetaxel for a median OS of 10.5 months, and the docetaxel alone arm was 9.1 months. And this translated into a hazard ratio of 0.86 with a p-value that was statistically significant at 0.023. In this exploratory analysis, which was subsequently published, again, the trial was not powered to do this exploratory analysis, but it was really looking at whether or not patients who rapidly progress gain benefit, whether or not from the ramucirumab plus the docetaxel. So they took different cutoffs for how quickly did they progress in their first-line therapy, and then analyzed each of these subgroups by whether or not their survival outcome, depending on which arm they were on in the REVEL trial. And so in the patients who received docetaxel ramucirumab, the bottom line was that all of these patients derived significant benefit. It appeared to be an increase of about a month and a half for PFS, and then also roughly about that 2 months for OS. And so it did appear that the ramucirumab and docetaxel gained some benefit to those rapid progressors from frontline therapy. And so if you look at the Kaplan-Meier curves for overall survival, and you lump together all of these refractory rapid progressors, the median OS for the patients who got ramucirumab docetaxel was 8.3 months, and those who got docetaxel alone was only 6.3 months. And this translated into a hazard ratio of 0.86. And again, this p-value, because this was not a design that was implemented into the trial, this was an exploratory analysis, so it wasn't powered for this analysis, it didn't reach statistical significance. But interestingly, in the progression-free survival in refractory patients, when you look at the patients who got docetaxel ramucirumab, their median PFS was 4 months compared to docetaxel alone at 2.5, and this hazard ratio was 0.71, and the p-value did reach statistical significance. So there did appear to be significant benefit seen in this refractory population of patients with docetaxel ramucirumab. When they did initial analysis in terms of quality of life, looking at symptoms, it actually appeared that ramucirumab seemed to improve side effects for these patients, toxicities from their malignancy, not from treatment. And it especially appeared to benefit patients for fatigue and also for dyspnea. Now again, exploratory analysis, so the confidence intervals do cross the line, but it is food for thought that this regimen may significantly improve our patients.